Hello, everyone. Good evening. Thank you for joining. We're going to get started in a few minutes here. We'll just wait for a few additional people to join. So hello, everyone, and welcome to today's webinar, Practice Pearl's Best Practice Recommendations for Single-Use Negative Pressure Wound Therapy in Community Management of Diabetic Foot Ulcers. My name is Subjit Van Kempen-Saket, and I'm the Medical Education Manager for Smith+Nephew Canada. Thank you for those who inputted questions so our speakers can address those throughout the presentation today. I'm pleased to introduce our guest speakers, Amanda Loney and Savea Menard. Amanda earned her Bachelor of Science in Nursing from the University of Western Ontario, acquired her WOCN designation from Albany Medical Center in New York, and has completed her IIWCC at the University of Toronto. With 30 years of nursing experience, 24 of those years as a certified nurse specialized in wound, ostomy, and continence, Amanda is a passionate advocate for excellence in patient care. In her roles with Bayshore Home Care Solutions and her private practice, she is recognized for her deep clinical expertise, dynamic teaching style, and dedication to advancing wound, ostomy, and continence care. An engaging speaker and consultant, Amanda has presented at national and international conferences and has published in the International Wound Journal, contributing to ongoing advancements in the field. Savea Menard earned her Bachelor of Science in Nursing from the University of British Columbia in 2009 and has worked as a surgical nurse in BC Interior before specializing in wound care. Since 2013, she has worked as an NSWOC in acute, community, and long-term care settings, bringing extensive expertise in wound care. Passionate about education, cross-team collaboration, and patient care, Savea completed her Master's in Nursing in 2021 and now instructs in an undergraduate nursing program and is an academic advisor for the Wound, Ostomy, and Continence Institute. She is an innovative teaching style and enjoys connecting healthcare practitioners with the practical knowledge to enhance their skills. Savea is currently pursuing her doctorate in distance education. A couple of housekeeping items before we get started. Get ready to participate. The speakers have several polling questions for you. We invite you to submit questions by typing them in the question panel found by clicking the Q&A icon along the bottom of the menu. Submit your questions at any time, and we will address them during the Q&A portion at the end. For your certificate of attendance, please complete the survey at the end of the presentation. Indicate that you would like a certificate of attendance and provide your name and email address. Now I'll turn it over to Savea to start the session. Thank you.
Thanks, Sub. Just gonna advance our slides. So our disclosures, this presentation is the opinions of mine and Amanda, and we are receiving an honorarium for this presentation. So let's get ahead, start with the first polling question. We're just asking, what is your professional role? So the polling will come up and you can just answer. It looks like. Awesome. We've got some LPNs, RNs, a few NSWOCs, and a wound care educator. Fantastic. Well, welcome. The next question we're going to ask, we're going to get you doing some polling today. The next question is, how confident are you with the use of application of single-use negative pressure wound therapy in diabetic foot ulcers or other wounds? Great. So we've got a little bit of a mixture, some people that don't have a lot of confidence, and we've got a mixture of slightly confident and somewhat confident, and 20% of you are fairly confident. Excellent. So we've got a whole mix of people. So we hope this presentation will be beneficial for all of you. Next slide. There we go. All right, so what we're going to do today is we are going to look at some of the evidence to support the use of PICO in diabetic foot ulcers, look at some best practice recommendations, and then we're going to focus in on some of those clinical considerations using various wound fillers and some little tips and tricks for you. And the last is hopefully to be able to develop strategies to increase your confidence in using single negative pressure wound therapy. So let's look at some of the statistics, and I love this slide because it really highlights the Canadian statistics that we're seeing. So currently, there's 3 million people that live with diabetes in Canada. I'm sure many of you that are working in practice are seeing this on a day-to-day basis. Up to 25% of these patients do have foot ulcerations, and unfortunately, a lot of these patients are really, really high risk for those surgical site infections. And something that I'm not sure if you are familiar with this statistic, but this is quite shocking that the rate of mortality following an amputation is anywhere between 20 to 40% after 1 year, and it goes all the way up to 80% at 5 years' time. So the reality with this is that 85% of these leg amputations are actually preventable. And so when we're looking at the amputations in the Canadian research, we see that up to 43% of these patients are fitting within that 40-year-old to 64-year-old category. So when you think about the patients that you're seeing in your practice, these are generally the people that are still having to work. Maybe they're looking after family members. And so there's a lot of challenges that come along with these individuals if they end up with an amputation. So there is a lot of evidence with negative pressure wound therapy, but this particular consensus statement focuses specifically on diabetic foot ulcers. So what we do know about diabetic foot ulcers is it's a really complex scenario, and we generally need a lot of support from all of our multidisciplinary team members. So when we're looking at providing care for diabetic foot ulcers, we're needing to do things like offloading, proper nutrition, blood glucose monitoring, and of course, excellent wound hygiene. But this particular statement really focuses on some specific considerations related to negative pressure wound therapy. The first one I'd like to highlight is the benefit of negative pressure wound therapy in the fact of the matter is that compared to conventional dressing changes, we do see a decreased number in having to do those regular dressing changes. So whether you're using traditional or you're using single, generally speaking, we see anywhere from 3 times a week to up to 1 time a week. This is something to consider in your practice because, of course, that's going to be a cost savings for you. You're not having to do those dressing changes as frequent. And the benefit for the patient is they're not having to come into the clinic as often. We want to make sure we're initiating that negative pressure after infection. I use this a lot for patients that have treated osteomyelitis, and it works fantastic. Negative pressure wound therapy has also been found very beneficial for skin grafts. And the last one that I want to highlight that they mentioned is the fact that negative pressure wound therapy for those patients that end up with extremity or toe amputations. So when we're dealing with these patients, what I oftentimes see in my practice is the patient goes into the OR, they end up with an amputation, and then I end up getting a referral perhaps on the floors or in the home care environment. And now they've already had that incision line open for a period of time, so increasing risks of infection. So applying that negative pressure in the OR really is beneficial for patient outcomes. And of course, further evidence is still needed specific to diabetic foot ulcers and the use of negative pressure.
Okay, so now we're going to go on to looking at assessment management and the treatment strategies and tools to support management of diabetic foot ulcers. So we're going to try and tie in some of that little bit of that research that we have, and we're going to show you how to actually get that hands-on approach to actually using it. So when we're looking at a poll question here, so everybody get out to do your poll question. What makes you think twice about using the single use of the PICO negative pressure wound therapy? So do we have the depth of the wound greater than 2 centimeters? So if it has significant depth, you're saying no to this. The complexity of application, you're thinking, gosh, that's too complicated. My nurses won't be able to do it, or I don't think I'll be able to do it. The drainage is too large, moderate to large drainage. Position of the wound, unlikely to achieve a seal. You just think, you know what, I'm not going to get a seal with this. It's going to be a waste of time. Or the actual cost of the negative pressure wound therapy. So what do we have there? Okay, so look at our answers. So we have the position of the wound, unlikely to achieve a seal. So hopefully by the time we're done this presentation, we're going to show you some of the kind of tricks to help get that seal. Moderate to large drainage, okay, we're looking at that. And the complexity of application, again, some tricks to kind of help get that down, and the cost. And I think that's a big one. So when you're looking at the cost of negative pressure wound therapy, hopefully you're going to take that into consideration as not just the cost of the actual dressing, but when you look at the cost of the actual healing of the wound in the whole, and that you'll see that this is actually probably a very, very cost-effective means of treatment. So let's move on and look at how does actual negative pressure wound therapy work? So when we're looking at surgically closed incision sites, so these typically we're using your disposable single-use PICO. This is typically what you're using that. Now, often we will use traditional if we have highly exudating incision lines. So if you have incision line that's kind of pouring out fluid, you can use traditional on that. But often we're looking at this single-use, the PICO. So what does this do? It helps reduce lateral tension forces. So often we see these wounds dehiscing on diabetic foot. So that actually helps kind of keep that together. Not only do the staples do this, but the actual negative pressure helps do that too. So it helps improve perfusion. And we know that the microvasculature on diabetic foot and arterial disease often happens with this too. So this actually helps to improve perfusion. It helps reduce edema. And I say this over and over again. I think this is the one thing that we don't treat enough, and that's edema. We think about, venous leg ulcers, like how do we treat those? We know that those are treated by addressing the edema. You must address edema no matter what type of wound it is. And this actually helps address that edema. So it reduces seroma and hematoma fluid collection. And a lot of that's with wicking away some of that seepage and also addressing that edema around there. And it protects the incision from external contamination. So when we're looking at this, and there's tons of literature out there that's showing you put a semi-occlusive dressing on top of a surgical incision site, and especially if you can get that in the OR, you're going to decrease your risk of infection there for sure. Now that's looking at surgically closed incision sites. So now we're looking at open wounds. How does that actually help with open wounds? So it does everything that it does for your closed wounds. It will still do that on your open wounds. But what else does it do? It helps promote granular tissue. So it helps contract our wound edges as well. So it helps bring those together. Okay. So, and everything else that we already talked about with regards to the closed, it will do that with the opened as well. So we're going to take a look at the overview of the PICO, and this is our single-use negative pressure therapy, indications, device, mechanisms of action. So let's take a look at this, the pump. So when we're looking at the pump, very, very, very simple. So you can see that we have the dressing there, and I have one here too. So this is just a dressing as you're going forward. You have a very simple mechanism of work, so it's not complex. And I know that I get a lot of nurses who don't use negative pressure on a regular basis, especially in my long-term care facilities. And you mentioned negative pressure and everybody's like, oh God, that's too complex. I can't do it. If you can peel and stick, you can use this device. So you just have a simple device. There's one button, on-off button, and then you have a green OK indicator. You have a leak indicator. You have you need your dressing changed indicator and a battery if your battery is low indicator, which I've never really had that issue with. You have a nice little belt clip there that you can use. And that's the extent of this device. So when you're looking at the actual dressing, so you can take a look at this, and this is where we're looking at getting that decreased wear time with these types of dressings. So the wear time can be up to 7 days. So typically, and that's going to determine what you're putting underneath your Pico and how much drainage is coming from it, but it can be left on for up to 7 days. Typically in my practice, when I first put those on, I change on day 3 and then I change on day 4, which would be the 7 days from the time, and then the pump is changed out. Savea, in your practice, what do you normally do?
Yeah, I do the same thing. I usually change on day 3 and then day 4 as well.
Yeah.
Sometimes I can get that 7-day wear time, but it depends on exit date.
Yeah, now after, and typically I do like my first application is that, just to make sure that everybody's good with it. And then as that wound gets on to healing and my drainage comes down, then that's when I'm going to extend it up to 7-day wear time with that. So, and when you're looking at how this actually manages, so approximately 20% of the fluid still remains in the dressing. And this is what prevents the wound from actually drying out too. So you're getting that moist wound environment with this type of dressing. And that is, and then you're looking at 99% of that bacteria is trapped in that core of the dressing. Okay, so that you're not getting any of the bacteria kind of sitting on the wound bed itself. It's actually sucking it up into the pad of that dressing. And that kind of that second layer from your contact layer, which is a silicone contact layer, that actually kind of disperses, wicks up and disperses that fluid out. And over 80% of the exudate is lost through evaporation. So this is really important to remember, that it's not just the dressing kind of containing that drainage, that it actually pulls it up into the dressing and then it evaporates out the top. So when you're thinking about, can I use negative pressure or Pico single use for my wound, you want to think about where are you putting that dressing. So if you have this on somebody's a breast or a chest wound or an abdomen wound or on a leg that's exposed or anything that's exposed open to kind of air, you're going to be able to manage a lot of that fluid. It's going to go, you're going to have a lot of evaporation capacity to happen there. If you're putting this underneath, let's say compression therapy, you're going to, or someone's sitting on it, you got to think about, okay, maybe I'm not going to get so much evaporation happening there. And that may determine like the length of time you're going to be able to leave that dressing on. So the soft port, and I have to tell you that in my area, we have been using the Renesas Edge pump, so the traditional negative pressure pump Renesas, and it has a soft port as well as the Pico has a soft port. So, and I never really kind of thought the benefits of the soft port too much. I just took it for granted. But now that I actually kind of had lost the ability to use the Edge in some of areas that I practice in, because we have a different pump, I have really missing that soft port. And we've actually had some issues with trauma happening to our patients because they don't end up tracking the port away from pressure point areas. So when you're looking at things like, you know, where is that port going to go? If it's not a soft port, you have to think about tracking that away. So it makes it quite complicated when you don't have that soft port. And the Pico has a soft port and the Edge both have the soft port. And I have to tell you, makes life so much easier. So I will put the Pico dressing underneath total contact casting. And I will do this because the dressing itself is an advanced dressing. So even if I happen to lose my seal, that I don't have to all of a sudden go, okay, I need to get that cast off, or I need to have the person come in or call in the middle of the night, because the Pico's already an advanced foam dressing all on its own. So they can call and tell me, you know, the next day or day 2, hey, my dressing, I sprung a leak. It's no longer actually functioning as a negative pressure dressing. It's still going to function as an advanced foam dressing. So I don't have to worry about that. And that soft port, I don't have to worry about causing any pressure injuries underneath casting, underneath total contact and casting boots, and under like cast walkers, orthopedic shoes. You can see on our final second last photo there, this lady wore an orthopedic shoe because she had a foot deformity, and I didn't have to worry about, you know, tracking that port all the way up her leg. And then you can see it in my last, and I know there was a question coming in for this, can you use it under compression therapy? And again, I can't stress the importance of addressing your edema when you have it. So your negative pressure helps address that edema to the peri wound, but you also need to address the edema for the full lower leg if you're using it on VLUs, or even in diabetic foot. and I've switched my practice too. I will always put someone in compression if their foot is full of edema, if their blood flow is okay. And I will use it under compression therapy. And it does, you have the ability to either hook it onto the side of the compression or they can put it right up. And I don't have to worry about that port causing any trauma. So this is the machine. You have just that small little machine. You have a 7-day one and you have a 14-day one. You can also use the Pico 7Y, which means that you can hook up 2 different Pico dressings to the same device. Okay, so if you've had 2 wounds that need to be separated, then you can hook up 2 and have just the one device running. Okay. So again, the Pico, we talked about it. This is good for closed surgical wounds as well as open. It's canister free and really portable. And we're going to talk about some of the perks of that and what our patients find as perks for that too. And it has, and we're going to talk about some of the unique features that this particular pump has in comparison to traditional negative pressure. So it's not just that it's a different application, it actually has different benefits too. And we're going to talk about that. So what type of wounds would you actually put single-use negative pressure on? And here's kind of a list of some of the wounds that everybody kind of knows of: chronic wounds, acute wounds, surgically closed incision lines. You have pressure ulcers or ulcers, subacute, the hist wounds, traumatic wounds, partial thickness burns, flaps and grafts. I'm a real big advocate of these now. I see so many flaps and grafts coming in that go bad. And if I know someone's going, I will often try and get that Pico in ahead of time to give them to go for that. And I find that I get much better outcomes for that. But I will put a Pico on any wound that I'm actively trying to heal. So if it's a healable wound and I have my wound bed prep done, and I'm actively trying to heal this wound, it's in an active kind of healing state, or I'm trying to get into that active healing state, there's not too many wounds I wouldn't put the Pico on at that point.
Okay, so as Amanda was saying, we're really focusing the single negative pressure wound therapy to Pico, and it's not like Pico or that single negative pressure wound therapy is the same for all of them. And so we're really focused on Pico. Now, I will get further into this randomized control trial, but what I wanted to do was just define for those of you that aren't familiar with the term traditional negative pressure wound therapy and single negative pressure wound therapy. So traditional negative pressure wound therapy is a device that has the ability to have that 25 to 200 millimeters of mercury. There's the canister, so that's where that exudate sits. It has the connective tubing, and when the patients are having their wounds packed, they either use foam or gauze fillers. When we're talking in this presentation about single negative pressure wound therapy, we're specifically talking about Pico. And as Amanda said, we'll talk a little more about the benefits of it. So we've got the battery powered pump, which she's already talked about. It's canister free, and it provides that continuous negative pressure where that dressing is situated.
Yeah, so I think it's important to realize that it's where the dressing is situated. So everything underneath that foam pad is getting that negative pressure of up to 80 millimeters of mercury. So it's not just the wound itself, because that pad goes onto the wound and it goes onto the peri-wound. And this is where we're going to see in some of our studies just how beneficial that is for your wounds. And you can see here that they did a CT scan after the application of a Pico. And this is kind of where it kind of hit home for me, as to I'm like, why are we actually getting better results with using the Pico versus traditional? And the reason is, and in my opinion, is that you're getting the benefits of the negative pressure, not just to the wound bed, like we see to the right there. That's just the negative pressure is delivering localized therapy to the wound itself. So it's only within the 35 millimeters of the wound center line that you're getting that therapy. Whereas the Pico, that expands right across onto your peri-wound out within 60 millimeters of the wound center line. You're getting that negative pressure therapy to that. And I remember way back going to a conference and someone saying that they did surgery and they were using traditional and they were draping all of the peri wound and then putting black foam on all of the peri wound to get that negative pressure to the peri wound. So very costly to do that, and you need to be kind of an expert to do that. You're going to get all those benefits by just peeling and sticking on the Pico dressing. So let's take a look at the summary of actually what the Pico does. It has multiple mechanisms of action that help improve the speed, the strength, and the quality of wound healing, leading to fewer dressing changes and faster healing of chronic wounds. And I think it's important to realize that you're actually getting, and they did, and I don't think we mentioned this study, but you do get, and I think when negative pressure first came out, I remember thinking everybody was talking about, oh, but what's the quality of the tissue that you're producing? And they've actually doing studies saying you're actually getting a good strength and quality of wound tissue that's actually forming in that wound bed. So it's not just like this fast hypergranulating growing tissue that's happening there. So you're protecting from external contamination. So you're decreasing your risk of infection, improve your wound contractures that we talked about. It stimulates that granulated tissue formation. It helps promote angiogenesis. It increases blood flow to that area, and it also helps reduce the edema. So we're going to talk about some of the things that you can put underneath your Pico dressings. So if anybody's heard me talk in the past about negative pressure, I will go off kind of like and think about different things that you can put under there. And you can put different things under there. Different companies put different things under their negative pressure. So, but with the Pico, they're the ones that they kind of recommend that we're going to talk about today. You can use the Acticoat Flex. You can use the AMD gauze, and that comes both in the ribbon and in just the PHME gauze. You can use the bigger Curlex and or just the gauze pads, and you can also use the black foam. So the question is, when do you need to use fillers? And I think we often try to actually use fillers too often. So I want you to think about this. When you actually need to use a filler, you need to use a filler. And this goes not just for a Pico, but for any of your dressings when you're using a dressing. So instead of just putting a foam on top of a wound, you need to think about, is the foam going to come in contact with your wound bed, right? So you need a contact layer to the wound bed. So if the depth of that wound is shallow enough that when you put your foam on top, that it's going to conform to the wound bed, it's going to go down into the wound bed, then you don't necessarily need to use that that filler, whether that be gauze or whether that be a black foam filler. So you can see the picture on the left-hand side there, we just have a 2 centimeter, but it's very, very shallow. If you have a 2 centimeter or more, and it's kind of got like a depth to it, like more of a cliffed edges to it, that's when you're going to need to think about, okay, when I put that foam dressing on top of there, that Pico, and it kind of collapses down, it's not going to hit my wound bed. It's not going to reach my wound bed, and that's when you need to think about, what am I going to do to fill that? And anything 2 centimeters or more, that's when I'd start to thinking about, okay, I need to use a filler for that. So what types of fillers? So you can use the gauze that we talked about. This is a really nice, easy filler to use. So if you're worried about your cutting skills, this is actually very easy to use. You just kind of fluff it into the wound bed. You don't want that gauze filler to sit onto the skin. You want it just to fluff it into the wound bed, and you don't want it to bulge on top of the skin either. Okay, so just level with the wound bed. And you can even just, so when you put it in there, it can just be level with the wound bed, and it can even, when it sucks down, it can go down a little bit. Don't worry about that. Okay, so you can use your gauze filler. You can also look at using the black foam. So the black foam is for your deeper wounds, wounds that you want, that you have like a thicker viscosity of your drainage to. It will wick away that fluid and pull it better than what a gauze would. So I wouldn't suggest using a gauze for more thick viscous fluid. I would use the foam for that. Gauze can be used for very little bit of fluid, serous fluid, serosanguinous fluid. That's when you're doing it. And the gauze filler, just like your traditional negative pressure, you would use this just cut to the wound bed size, and you would put that into your wound bed. and don't crush it down. So you just want it to kind of fit into that wound bed very nicely. It can overlap a little bit when you first put it in. When it crushes down, it will go level with the skin. Okay, so that's how you would put in that. And then you go ahead and you would put your dressing on top. When you're using fillers, you got to think about the contact of that filler. Whatever you decide to use is going to determine how long you can leave your Pico dressing on for. So if you're using gauze fillers or foam fillers, typically 3-4 days max I would ever do with a gauze and or a black foam filler. And depending if I was using something like Acticoat or Acticoat 7, I potentially would leave that on up to 7 days. But you got to think about what you put under there and what you would normally leave that contact layer there for. So if it's a contact layer that you would only normally leave under a dressing for 3 days, then you would only leave it under a Pico for 3 days, okay? And that you would need to change that. Okay, so just going over loosely fill, fits inside, and we actually did all that. Okay, and we talked about all that too. Really avoid overpacking, and I see this quite often. And the one thing I want to mention too is you never put the black foam on the healthy tissue. And another thing I see people do is like traditional negative pressure, people want to picture frame their wounds. You do not picture frame the wound underneath the Pico dressing. Okay, so this makes it much simpler. You do not picture frame your wounds to the peri wound. You put the black foam in, you're dressing on top. Okay. So the question, one of our polling questions, when would you not use it? And, some of the people said deeper than 2 centimeters. So typically, historically in the past, the Pico has been used for very kind of surface wounds. And we typically would just put that on, and then we started putting maybe Acticoat underneath it. And now we have fillers available to us. So how deep can we go when we're using that Pico dressing? So they've done studies and they say up to 4.5 centimeters, they're still getting that negative pressure there. So when I'm thinking about, can I use the Pico dressing to my deeper wounds, I need to think about, am I going to be able to pull that fluid away, right? So if the wound gets too deep, you're going to have the pooling of fluid, and that's not going to work. So if you take off your dressing and you're getting a pooling of fluid underneath your packing, then you know that that's not appropriate. But it can definitely go up to 4.5 centimeters. I've used it for deeper wounds too. You just got to make sure that the fluid isn't pooling underneath that dressing and you're able to manage your exudate. And that really kind of is what kind of a key. And we're going to show you how to kind of think about, do I need traditional or can I switch to a Pico? Okay, so when we talked about the fillers, and we kind of mentioned this too, and one of the things that we're looking at, when I got this gentleman, and you can see kind of the picture on my screen here to the lower right, you can see that I had this gentleman and he came across, and this was someone's version of a disposable negative pressure. When I said to put single use, this is a single use negative pressure. It is not the same thing as using a single-use Pico negative pressure. This is basically a throwaway traditional negative pressure system. And it doesn't give the same perks that we're talking about when you're looking at Pico as a single use. So you have the port, and you got to think about what is actually, do I even want black foam on this type of a wound, right? Do I want black foam sitting on top of my bone? Do I want it sitting on top of my peri-wound skin? It makes it much more complicated than using the single use, okay? The single use Pico. So you got to think about when you're talking about that. And up in the top here, we just talked about the fillers. We don't want it bubbling up, okay? You don't want to overfill it. So you can see here the ease of putting something like this on, and due to the soft port, I don't have to worry about actually where my soft port is according to his boot. So right here, I put a collagen dressing on. I don't have to be an expert at cutting and pasting and picture framing my wound. Collagen dressing on, Acticoat on, put the Pico dressing on top, and I've got negative pressure. I've got negative pressure to the wound bed. I've got negative pressure to the peri wound, and I'm going to get the benefits of that. And we're going to talk about some of that in our studies. So take a look at this. Which dressing needs to be changed? So when you're looking at this, so if I see dressing A, do I need to change this dressing? And often you can call up your patients and go, hey, what does your dressing look like? A, this is acceptable. You can leave this on. You do not need to change it. B, potentially you may need to change this type of dressing. So you want to be very careful, and we'll talk about this a bit when you're placing Pico dressing. Unlike traditional negative pressure, we like to put that port right on the heaviest portion of the drainage. So we want to suck that drainage away. So we put the port right where we think all the drainage is going to be. Typically, that's what our goal is. With the Pico, that port, that soft port actually wants to be as far away from your wound as possible. So don't put it on the bottom side where, you know, gravity is going to pull. You want to put it up. And when you're choosing your dressings, we're going to talk about that too. You want to choose a dressing where that port's not going to be over top of the wound, because it could give you that artificial, you need to change that dressing sooner than what you really do. Okay, so you may want to be looking at changing that one. And you're looking at the bottom one here, when your dressing is fully saturated, you want to be looking at changing that. And often you will get that little indicator light saying dressing needs to be changed. And so your patient knows it needs to be changed. Your nursing staff knows it needs to be changed. So it's pretty easy. There's no guessing, you know, whether you need to change that. And if you take a look at that last picture, you know, that's a lot of drainage in there. And so you're getting that, it's managing that fluid through evaporation. We didn't have any leakage there, and we didn't have any maceration with this. So it actually manages quite a bit of fluid. Again, as long as you're able to get that exposed to air so that you get some of that evaporation happening, and you can manage quite a bit.
Excellent. So as Amanda was just saying, around even with the one that did need to be changed, this particular study looked at the comparison between traditional and Pico, and the interesting outcome was that there was actually fewer dressing applications per patient with the Pico. So you would think, oh, that's really interesting. But when you think about traditional, generally we're changing it Monday, Wednesday, Friday, or 3 times a week. But with diabetic foot ulcers, when they were doing the dressing changes, they were getting on mean average of 6.5 days. So now you could get up to the 7 days. However, we're going to talk a little bit further as to when to decide when what's appropriate moving from traditional to Pico.
So looking at your dressings, here's all your sizes. I'm not going to go into too much talk about this. And we did talk about when you're thinking about your size, just think about making sure that the wound fits underneath the pad. The heavier the drainage, kind of like think about the bigger the pad, because then you're going to be able to manage that drainage. And there's no real kind of downsides to kind of like over guesstimating the size. Like, so if anything, I'd go up a size as long as geographically you can manage that. And you don't want your port typically underneath your wound. It doesn't hurt if it does, but if you're draining a lot, it could give you that false sense that you need to change that.
Thanks, Amanda. So when we're looking at different practices, we recognize that across the country, there are a lot of differences. So Amanda's in Ontario, I'm in British Columbia. And when we're looking at patients transitioning from traditional to single negative pressure wound therapy, it's going to be variable depending on where you work. Specifically acute care though, Amanda, what is your current practice when patients are transition from acute care to community with the use of Pico?
Yeah, so unfortunately in my practice is that when somebody is, and I don't think that they use it in their head, we're slowly starting to see that transition into using Pico in hospital, but I think they tend to be very much using the traditional edge negative type of pressure therapy. And unfortunately, what happens is somebody's on negative pressure in the hospital, and when they're transferring back into the community, their negative pressure gets stopped. And then the person comes out into the community, and then it has to be kind of like reassessed, the supplies ordered, and then you get that disconnect happening there. So that's like super unfortunate. And I think if you looked at being able to use put on somebody on a Pico in the hospital, they can get home and that transition can happen better. And I know you guys actually, you transition your patients with the traditional. Is that what happens?
Yeah, that's correct. So generally speaking, patients are transitioned with the traditional rental systems. And then once they go into the community setting, that's where generally we determine whether or not they get transitioned to the PICO. And so in many of these cases, I'm going to show you a quick example of a patient who is a 48-year-old person that ended up with a surgical debridement. This particular patient had traditional negative pressure on for 2 weeks in the community setting. And what they did was they transitioned the patient to PICO. Within 7 days, you can see here the difference between the application and the 7 days of a 30% reduction of wound volume and drainage. The other great thing to consider is the patient's age, and the fact that this patient's in a community setting. So being able to mobilize with this product and to be able to just manage their activities of daily living is much better with the use of PICO.
Yeah. And again, I mean, we all know that with diabetic foot, I mean, gold standards, you got to offload these people. And when
Yes.
you're using that traditional, it becomes very challenging to offload. And then you're trying to track that pad up their leg if you don't have the soft port available to you. So looking at, and everybody's like, okay, so great, PICO is good. When can I use PICO? So if you're still kind of a little confused about when you need to use PICO versus when you need to use traditional, well, we've developed a tool for you. So one negative pressure clinical decision tree for open wounds was developed. And we're going to kind of go through a couple of case studies using this. This will walk you right through of what you need to use. Do I need to use traditional? Do I need to use PICO? Do I need to use a filler? So you can actually just Google this. It will come up. I've looked at it before, and we'll use this to walk through. So we have a case study here. So we have a 55-year young male patient, and he was in the hospital. You can see his wounds look kind of horrendous there. And they wanted to do an amputation. So he was like, no, I don't want the amputation. He's got sent home. I got this photo sent to me. His wound looked like it was horrible. You can see he's got all these tunnelings. He had pitting edema to the foot and lower leg. He had uncontrolled, untreated diabetes. So what we're going to do. So here we are, 1 week following good hygiene. Again, can't stress enough of hygiene. Just look how much better that foot looks just with cleaning it up. So he was in the hospital all that time. We get him home and we actually give him some good wound hygiene. Can't stress this enough. So now we're looking at what are we going to do for him. So we need to make sure this is kind of a long trip. You need to make sure that you have, this is when you need to have a team approach. You need to have your infectious disease on board. You need to have somebody who's going to do some surgical debridement for you because conservative will take way too long. You need to make sure you have your diabetic team. This is a team approach. Okay, so after 7 months post initial assessment, this took a long time, and I was like sitting there waiting for this guy, and I like called up my surgeon that I deal with for diabetic feet, and I'm like, hey, like, what are we doing here? This guy is young. We're just not going to leave him sit with, eschar on his foot. So we got some surgical debridement happening here. So on the left side, we see the surgical debridement happening. Then you see my conservative debridement happening. And now what are we going to do with this? So we have a poll question, a treatment plan. So what are we going to do for here? What would you use? We have large seropurulent drainage. We have a foul odor happening. The peri wound was intact with very slight maceration, non-weight bearing, pitting edema to the foot and lower leg. So here's some of the things that we can look at using. Do you want to use Santal? So we know we need to kind of debride a little bit more here, but you can start to see some of those, the granular tissue coming through. Acticoat Flex in a Leave in Life. You got a foam happening, an antimicrobial, no high risk for infection. Durafiber, a leave-in adhesive foam dressing, Iodosorb. You have so many options. Traditional negative pressure, the edge, or do you go with a PICO and an Acticoat? So what would you do? So what are our poll questions here? Okay, so people, we're talking about PICO. So most of people said, 64% said PICO and Acticoat. We do have a couple saying the edge and Iodosorb, Mesorb. So none of these are like really that wrong. I mean, you got to think about, am I managing my moisture? Am I going to do my debridement? Those are the big key things that you want to be thinking about. Okay, so let's walk through this and find out what we're actually going to do here. So, does the wound fit comfortably under the PICO dressing? Absolutely, you can get a PICO dressing that would do this. So it's still in contention. What is my level of exudate? So I said he actually had moderate to high level of exudate. So when you have moderate to high level of exudate, you know that you're going to shift over into your traditional negative pressure, because when you're dealing with that high level of exudate, you're going to end up changing that PICO dressing like daily or every other day. We have uneven. I do want to use a little bit of mechanical debridement with this as well. So I know my black foam gives me a little mechanical as well. So here we go. We did go with the traditional edge negative pressure dressing. And this is where, if you're not super good and keen on picture framing your wounds, you can use your like a hydrocolloid, thin hydrocolloid, or your Tegaderm around the wound. That way you don't have to be perfect with cutting. I did layer a layer of Acticoat on there because infection was still a really big consideration here. You can see here just how I kind of held my black foam in place. And then I go in ahead and draped. And he is non-weight bearing, so I wasn't too concerned. But even when he was using an offloading boot for a little bit, again, that soft port is not really an issue at all. But he wasn't really walking. So when do you transition? So here we are, we have this guy. Now what a look at his wound. It's nice and clean. And we have the drainage in the canister is, you know, that's small to moderate drainage there, not a heck of a lot. So when you look at, is the exudate 300 mils or less, then you can look at the wound size. Does it fit underneath? Then you can think about, can I transition? Okay, so we have moderate serous. We have 3 opened areas actually on him. He has one to the midfoot. You can't see the one on the back of his heel, and I want to be able to address all 3 of those. So let's take another poll question. What are the most common complaints of your patient when they are using traditional negative pressure? Okay, I have difficulty moving around. I'm unable to get a good night's sleep. It's noisy, it beeps. The device is heavy and uncomfortable. It's embarrassing to carry. Other.
And Amanda, as we're waiting, let's follow through with the slide 49, where we're following through the next steps of application after that polling.
Okay, so we have a big thing of things, and it's all of these, right? I mean,
yes,
it's all of these. And you know, some of these traditional negative pressures too, they have a horrendous smell to them as well. So you got to watch that. I have a lot of people complaining about that. I'm not even sure we put that in there. Okay, so we'll walk through that actually in one sec. I think your next one is
we'll go to the next slide though. Yeah, keep going.
We're skipping these?
Yeah.
Okay.
Just for time. So basically with the Kersner report, they did find that the PICO was significantly more beneficial than the traditional negative pressure wound therapy. There was a lot of benefits in terms of patient satisfaction as well. As we go back to that poll, many of the complaints that the traditional was oh, sorry, can you go back one slide? Just
yep.
Sorry about that. Oh, there we go. Just in terms of the PICO, what they found was that there was a lot more benefit in terms of the patients were able to sleep at night. So as most of you mentioned, sleep was a big issue. The other thing is mobility. So patients are able to mobilize a little bit better with that PICO. And look at this, the overall satisfaction was far superior to the use of PICO over traditional.
Yeah. It just makes life so much easier for them.
Yes.
To move about. And not only your patient, it makes it so much easier for your nurses too. Like how many times will I get a nurse going, yeah, I can't do negative pressure. I can't do negative pressure. Long-term care, they're like, sorry, we don't have anybody trained. We can't do it. You don't need to be trained on how to peel and stick a dressing. Okay, this is what this is. So when you're walking through this, you can see this just walking through it. You know, does it fit comfortably underneath it? What's my drainage? Do I need a filler or not? So this is optional for this person, whether you need to use one. And we talked about when you would want to use that filler or when you don't need to use that filler. And this one actually fits underneath the Pico. And you can see here that he fit underneath the Pico quite nicely. And just the outcome of this. So 14 months till full closure. This was from a patient who was in hospital and they wanted to amputate. Okay, so he was extremely happy. So when we're looking at tips and tricks on how to put on this type of device, so you need to think about everybody when you're looking at, and we're talking about the diabetic foot here, and everybody's complaining about those toes and getting around there. Just make sure your like strip paste. I actually keep this all the time on me. You can also use the rings too. And one of the other things that we looked at was, I mean, how many times do we get these patients coming in? Yes, I'm wearing my offloading shoes all the time and their dressings all sheared off. So what can you do to help with that? You can actually use that gel sheet. Okay, so there is that Renaissance gel sheet, and it comes like a sheet like this, and you can put that around your wounds, and that will help kind of give a better adhesion. So typically, I would say don't ever picture frame your wounds, but this gel sheet you can use in creases. I will use it in creases in the groin and stuff like that, or around the toes. I will even stack it if I need to get that adhesion. Okay,
So
so
let's just move on to
yeah.
poll 7, Amanda, and we're just going to check in with the audience just to see how they're doing in terms of confidence in relation to single negative pressure wound therapy and diabetic foot ulcers. So we'll just move forward into that polling question, which I think is
No.
sorry. Thank you. Yes.
There you go.
Awesome.
So how confident are you with using the application of Pico single-use negative pressure? What do we got now? We got fairly confident. Very
Awesome.
confident. Okay, so that's
Great.
good.
That's fantastic.
Okay, so we'll move on because we want to make sure that we get a chance to answer, because I know there's lots of questions. So we're going to look at the summary. Savea, do you want to do that?
Yes, sure. So really just really considering to make sure that we're assessing and evaluating. So as Amanda showed, the one decision tree, the negative pressure wound therapy, you can look at that as a guide for you to be able to determine when to use traditional, when to transfer over to Pico, or just when to make those decisions. I recommend going through the consensus guide. It's excellent. The RNAO 2024 best practice guidelines is also fantastic. And so that is the end of our presentation. We'll conclude with that. Thanks, Sub.
You're welcome. Thank you so much, Savea and Amanda, for an engaging presentation and discussion. I've got several questions here in the chat for you, so I'm going to start with a few of the quick questions here. First off, is a physician's order needed for to order a Pico? 2 questions.
Savea, do you want to take that one?
Yeah, I think it depends on where you work. I would go back to your organizational policy. Personally, as an NSWOC, I do order the Picos as a registered nurse. It is within my scope of practice within BC.
And I think you want to just check into your own environment where you're working.
Yeah.
I order it all the time on my own as well in my area. So NSWOCs, wound consultants can order this. You always want to make sure is who is the person that's overseeing the care, and make sure that you check in with them.
Perfect. And another question here. Do you use iodosorb with Pico?
So, yeah, and anybody knows me, I do use a lot of different things underneath Pico, and I would use iodosorb powder underneath Pico for sure. I have used that from time to time. Not so much the paste, because I find that can kind of like potentially kind of gum up a little bit, but I would use the powder underneath Pico for sure.
Savea, anything to add to that?
Yeah, no, I generally don't use it in my practice, so it wouldn't be something that I would use. I just find it would get really gummy, especially the iodosorb paste.
Yeah, I agree. The powder is the one thing I would.
Yeah.
And it depends on what I have available. Typically, Acticoat Flex, it allows for that drainage to go if I really want my antimicrobial. But sometimes it depends on what you have available. The powder doesn't tend to kind of, you know, if you put a light dusting, the powder doesn't tend to gum it up. The paste or the
Ointment.
I would
Yeah.
probably stay away from using those. It's not that I wouldn't use it, especially on a smaller wound. You could.
Great, thank you. Another question here. I know you talked a little bit about the Renesis gel patch to achieve a seal. Do you need to use a spray like Cavilon to get a good seal?
No, so typically that's not something, and I often do not use a barrier spray underneath my Pico, right? So I really do want that silicone layer to come in contact with my skin. I think that you get better moisture balance to your peri wound for that. Now, sometimes the actual underneath your tape border, occasionally you can. Some people's skin are different. So sometimes I find if I do put a barrier wipe on some people's skin, I get better adhesion. Other times it's not. Sometimes you have to kind of play that by ear. But typically that's not something I reach for unless I think they're kind of having, you know, they're sensitive to the tape. Or sometimes some people like to put it in between the tape and the skin to kind of seal that tape so that you don't get it going up. But you are using your kind of tape border strips that go on the side, so I don't tend to get that lifting. So it's not common in my practice. It's not that I wouldn't do it.
Perfect. Savannah, anything to add to that?
No, I agree. I totally agree. That's the same thing that I do in practice as well.
Okay, perfect. A question regarding fillers here. Asking if gauze would stick.
It can. But that being said, if your wound, again, you have to be thinking about a moist wound environment. And when we look back in that other that slide, it doesn't like suck all of your fluid away. Like traditional negative pressure will suck all of your fluid away. And that's one of the perks of using the Pico is it does trap a little bit of that moisture. It leaves a little bit of that moisture there. So if you're finding that the gauze is actually kind of sticking, it sticks less than black foam would. For sure. So I don't find I still get that same adhesion you would with the black foam. So I don't have a huge problem with it kind of sticking. If it does, you need to think about your moisture balance. Savannah?
Yeah, that's what I was going to say. Then you need to be thinking about the moisture balance because, I mean, with the Pico, it should maintain that nice moist balance. It's not going to like dry and become hard to remove necessarily.
No, I've never had that experience.
Yeah.
Okay, another question here in terms of fillers. Could you use it on tunneling wounds if under 4.5 centimeters? And if so, what would you pack it with and cost?
So would I pack something with a tunnel underneath a Pico? Absolutely, I do. And I know that with the diabetic foot wound that I just showed you, he had actually kind of like a tunnel in the back of his heel. So you could pack it with different things. So you can pack it and we talked about those packing, the slide with the packing. You can use AMD ribbon packing. You can use Acticoat packing. You can use, it depends how big your tunnel is. You can use a thin piece of your black foam. Be careful because that doesn't have the same integrity as some of your other things. I will, in my practice, also use like hydrophilic blue tunnel packing because that actually does wick very nicely that fluid away. You just need to be thinking about, is the fluid going to wick through or pull into the Pico dressing, whatever you're using? It has to be able to wick and pull that fluid when you're doing that. But absolutely, you could pack wounds. And as long as you're not seeing that pooling of fluid when you remove that dressing, then you know you're getting the negative pressure and the pulling.
Yeah.
Savannah, what do you normally use for packing?
Yeah, generally it'd be the AMD or the Acticoat is generally what I use. In terms of cost, it really depends on what product you're using and whatever your organization, whatever their cost is. You know, I find that that's where you're going to go. And then also look at the timeline, how long the dressing can last in the wound based on the IFUs, because that'll sort of tell you the cost association with them. So if you have a 7-day antimicrobial, it's going to probably be a lot more money than a 3-day, just as a general rule.
unless you're leaving it on 7 days.
Yeah, true, exactly.
Thank you both for a very, very engaging presentation and addressing all these questions. There's a number of other questions that are in the chat. We will do our best to get the answers for those questions to you. But I really wanted to just take a moment to say, I hope you enjoyed today's webinar, Practice Pearls and Best Practice Recommendations for Single-Use Negative Pressure Wound Therapy in Community Management of Diabetic Foot Ulcers. And I hope you've gained some valuable knowledge that you'll apply to your practice. Your feedback is very, very important to us and is essential for us to help improve these educational sessions. So at the close of this webinar, a survey will pop up. If you can please share 1 to 2 key takeaways that you will implement in your practice, that would be great. If you do need a certificate of attendance, there is a question in the survey pertaining to a certificate of attendance. Please include your name and email address, and a certificate of attendance will be emailed to you next week. There are a couple of questions that came up pertaining to cost. If you would like for a Smith+Nephew representative to reach out to you, please indicate that as well, and someone can reach out to you with respect to coverage and cost for your specific area. If you have any questions, please don't hesitate to email myself or contact Wounds Canada at info@woundscanada.ca. On behalf of Amanda Loney, Savea Menard, Smith+Nephew, and Wounds Canada, thank you so much for joining us this evening, and have a good night.
Thank you.
Thanks.